Hi, this is Brian Kim. I want to share with you this case of a patient who self-referred. This is actually an interesting case. This is a patient who had cataract surgery and then was having terrible dysphotopsia. And so what I think happened was the surgeon was trying to take the lens, the three-piece lens, which was in the bag, and try to do some type of optic capture, reverse optic capture, or reposition it into the sulcus. And while the surgeon was trying to do this, they had significant zonular damage. So it just ripped the zonules. And so then the surgeon just kind of just left it alone. Unfortunately, the damage was already done. And so the patient ended up having a dislocated and shifted lens due to the zonular damage. And of course, it didn't really fix the dysphotopsia issue. As you're going to see me removing this dislocated three-piece lens. Again, there's significant zonular damage. The bag is damaged. Remove some of that as well. And then performing the modified Yamane technique using the sensor lens. And I'm able to do this because I externalize the leading haptic through a contralateral limbal incision. And so you can see here, this is the lens. You can see that the optic is captured in a very unusual way. But more importantly, there's significant zonular damage. You can see there's iris atrophy temporally as well due to all that manipulation. As I'm touching the eye, you can see there's quite a bit of IOL denesis and just jiggling of that lens. It's clearly not very stable. And so I'm using a Wexel sponge, again, partly to assess the stability of the lens bag complex, which you can tell is jiggling quite a bit. But I'm also drying the surface of the eye so I can mark the conjunctiva with the 27 gauge cannula. Again, I've inked the tip, marking on the right side first, and then the left side at the limbus 180 degrees apart, using the cannula to find that location. Very simple and easy, and plus you have the cannula in your hand anyway. No reason to use any other instruments. So this is a fixed caliper. I'm going to indent posterior in radial fashion, 2.5 millimeters posterior to the limbus, and then 2 millimeters adjacent, making sure the eye is dry. Go ahead and use that inked cannula to ink those marks. Again, nice and discreet marks, very precise, and this can only be done because the surface is nice and dry. Doing the same thing on the left side, indenting 2.5 millimeters posterior in radial fashion and 2 millimeters adjacent, drying the surface, and then inking the indentation marks with the 27 gauge cannula. Again, the Wexel is great for drying, but the cotton tip is better for manipulating. So this is the trocar. I indented 4 millimeters posterior to the limbus, and then turning the eye with the cotton tip, I'm tunneling about 3 millimeters towards that mark, turning perpendicular and then diving down. And you know this is going to be a self-sealing incision because the trocar is sitting slightly tangential. And these are my marks, first on the right side and then the left side, for externalizing this dislocated lens. This is the mark to externalize the leading haptic. And again, this is 90 degrees from my conjunctival marks. This is the incision for my 22 gauge thin-walled AC maintainer. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium. This is a 3 millimeter diamond blade, and the incision is going to be 90 degrees away from the conjunctival marks. These are microforceps, lifting the lens up with one forceps and then grabbing the optic with the other. And very carefully, I'm trying to pop the optic up out of the bag. I have the optic in my right hand and I'm trying to tuck the left side haptic with the forceps. Good. Tucked it, and then it came out. Grasping the optic with the left side forceps, and then trying to pop that right side haptic up with the right side forceps. Okay, good. So now I have both haptics in the anterior chamber, which means now the lens is stable and has a lower risk for falling into the vitreous space. Take the right side forceps out and now replace it with the scissors. And I'm trying to figure out where I should cut to bisect the IOL. And you can use this scissor as a manipulator as well. You can just grip it with the teeth and using both the forceps and the scissors to manipulate the lens into the position you want before cutting it. So I go ahead and grasp it, and I start cutting the lens completely in half, making sure I don't cut the iris. Obviously, the bag is completely shot. Okay, it's completely bisected. Switching the right side to the forceps and then pulling out the left side piece. Why did I pull out the left side piece? Well, it's because the haptic came off the optic. So you can see I pulled that optic, the left side optic, out. That half piece came out, and now I'm grasping and pulling out that haptic. The haptic just popped off. So obviously this lens was really not a stable lens. And then grabbing the second half of that piece and pulling it out. Again, this is the 22 gauge thin-walled AC maintainer. Did not have to widen the incision. Steri stripping it down. This is a 25 gauge needle, bending it, again, pretty close to the tip, making sure that the bevel is facing towards the right. This is the 30 gauge thin-walled needle. Again, everything's mounted on a syringe with BSS to avoid any bubbles. Bending it about 9 millimeters from the tip and making sure the bevel is going to be facing towards me. That's for the right side. The left side is going to be bent at the hub with the bevel facing away from me. Going ahead and doing some vitrectomy. Again, throughout this entire case, no evidence for vitreous in the anterior chamber, surprisingly. Doing some vitrectomy and eating some of that capsule or bag, which will be in the way. This is the cartridge for the sensor lens. Go ahead and put some cohesive viscoelastic on the cartridge. And then very carefully placing the lens into the cartridge, making sure it's seated down, making sure the haptics are oriented properly, seated down, pushing down on the optic so it bends concavely. The leading haptic comes out straight through the barrel, and the trailing haptic comes out from the back end. Placing the cartridge into the injector, pushing it all the way in, and making sure the trailing haptic is outside of the barrel, which it is. Advancing the plunger and advancing the lens, you can see that the leading haptic is straight, which is great. So now I'm going to internalize a 25 gauge needle through the contralateral limbal incision and then placing the injector through the 3 millimeter incision. My surgical assistant is advancing the lens. As the leading haptic comes out, I dock the haptic on the bevel of the needle. It slides right into that needle. And as the lens is being advanced, I pull the needle out. And so the leading haptic is out of the incision. And then I take over, making sure the optic comes out properly, and then swinging the trailing haptic towards the right. Pushing some dispersive viscoelastic to push the IOL back, grabbing the incision, and then this is the skull fixation on the right side. Again, making sure that needle is stabbing the conjunctiva and underlying sclera, stabbing, turning on infusion, tunneling 2 millimeters, turning on infusion again, keeping it on, and then diving down. So again, I made sure I went 2 solid millimeters, which will achieve a nice scleral shelf. Infusion is on again. I'm sliding In order to position the lens properly, you saw I was using the microforceps to pull the leading haptic out a little bit more, and then I'm sliding the trailing haptic in. And I like to slide it sideways when I do this. I'm getting caught a little bit. I think it's because the optic is getting snagged on the AC maintainer. So again, I don't like to just shove the haptic in. If you shove the haptic in, you're going to bend it. Again, with C2 Lucia, no problem. But with this, you would probably kink the haptic. So rather than just shoving it in, I'm just trying to gently slide it in, turning it a little bit sideways. And the main thing is not to be impatient, not to get frustrated, and just to take your time. Turning on infusion, very carefully try to. So I keep getting caught on the incision, but then finally I was able to slide it in, and then docking the haptic on the bevel of the needle, and it goes right in. So again, multiple attempts. I was getting snagged. I didn't want to put too much pressure on the haptic, but I took my time. I was able to finally slide the haptic in without causing any damage to the haptic, and I was able to cannulate the right side needle. Pull the leading haptic through the contralateral limbal incision, grabbing the incision contra-incisionally. So that's kind of the newest thing that I'm doing now, grabbing the incision contra-incisionally. Again, I'm stabbing the conjunctiva and sclera at that first mark, tunneling 2 millimeters, and then diving down. By grabbing the incision contra-incisionally, this prevents the eye from turning away from me. So that's kind of the newest thing that I'm doing. And remember, I'm turning infusion on when I'm tunneling the needle through the sclera. Now that the needle is in the eye, it doesn't really matter so much as far as the infusion. Trying to find the leading haptic. I don't know if you noticed that I subtly pronated my wrist, and that I was able to dock the haptic on the bevel needle, and it went right in. So go ahead and pull that left side needle towards me, grasping the haptic with the microforceps, turning off infusion, drying the surface of the eye with the Weck-Cel sponge, again keeping infusion off, and then cauterizing the tip and getting a nice bulb. Doing the same thing on the other side, pulling the right side needle away from me, making sure the microforceps are ready to grab. Turning off infusion, drying the surface of the eye once again. Remember, if there's a lot of water, then you're not going to be able to cauterize the haptic. So again, drying the surface of the eye, infusion is off, and then cauterize the tip. Again, you can see a beautiful flat position of the haptics. It's nice and flat to the sclera, which means I've achieved a great stable scleral shelf for the lens. Pushing the haptics flush to the sclera, and then reapproximating the conjunctiva, and you can see a well-centered lens now. You can see there's some remnants of the capsular bag. I didn't really perseverate and try to go after all those pieces, but I got rid of most of the pieces, especially the part that was going to be within the visual axis. So this is a tenonylon suture. Go ahead and close the main incision. And again, I always like to place a tenonylon suture in these cases since I had encountered vitreous. Go ahead and do some more vitrectomy through the trocar. Again, I haven't really encountered any vitreous throughout the entire case. Even when I removed the dislocated lens, I didn't really see any vitreous throughout the procedure. Doing some more vitrectomy through the limbal incision, but again, as I'm doing this, I don't really see any vitreous. There's a little bit of capsule remnant there, so I'm using the Multimate to retract the iris, so I can just trim that with the vitrector, and I'm retracting that iris so I don't accidentally eat the iris. So you can see a perfectly centered lens. Again, when the haptics were pulled out and the tips were cauterized, you know that this is going to have a good lens position because, again, there was no flagpole sign. Nice flat position of the haptic, flat to the sclera. So this is a surgical PI. I'm going through a limbal incision contra-incisionally. Have the port down, and you can see there's a flat, low cut rate, low aspiration but high vacuum, which means it's to be able to grab it. And once you grab it, it's not going to actually pull the iris into the port so much, but you're able to apply that high vacuum to be able to cut and then clear the tip. Nice and discreet, peripheral PI, small and discreet, but not so peripheral because you don't want to hit the ciliary body. Go ahead and hydrate the incisions, and I'll remove the AC maintainer. I'll remove the trocar, making sure that the sclerotomy is self-sealing, and this will be the end of the case. So again, this is a patient who had a 3-piece lens in the bag. Patient had apparently some dysphotopsia symptoms, and then the surgeon felt like maybe they could go ahead and take the lens out and try to reverse optic capture it or maybe put in sulcus. For whatever reason, he struggled. And it's probably because the patient had just bad zonules, but it was made worse because as they did it, not only was the lens not in full reverse optic capture, but the lens was shifted. You can see there was zonular dehiscence on one side, and the patient just was not very happy. And they sensed that something went wrong with that lens repositioning because it didn't really help her symptoms. And so went ahead and removed that dislocated lens, carefully pulling the lens out of the bag, again using a two-handed technique with forceps to compress the haptics, dialing the lens up into the anterior chamber, bisecting the lens in half, pulling each piece out. The left side piece, the haptic broke off, so I was able to just pull it out. And then performing my modified Yamane technique, externalizing the leading haptic through a contralateral limbal incision. Again, making sure I'm nice and flat, tunneling through the sclera, making sure I have infusion on, a nice firm globe, so I can tunnel properly, 2 millimeters, and then diving down. Again, docking the haptic on the bevel of the needle, and always turning the needle towards the haptic and not the other way around. Remember, the haptic is floppy, the needle is strong, it's made of metal. So you want to turn the needle towards the haptic. That makes the most sense. And so I do that every time. I'm able to very carefully dock the haptic on the bevel needle. You saw with the trailing haptic, I had quite a bit of trouble because I was getting snagged on the incision, but very carefully, just very patiently, I wanted to slide it in and push it in. I didn't want to just shove it in and bend the haptic and damage it. But after some patience, I was able to finally achieve it, slid it right in. As you saw, I was able to dock the haptic on the bevel needle, and it went right in. It was pretty easy and pretty straightforward. At this point, I noticed that there was some vitreous coming to the AC maintainer incision. So I go ahead and place the AC maintainer in once more time, and I removed that vitreous that was stuck within that AC maintainer incision. I'm placing that AC maintainer through a different incision in order to do this. And so because that AC maintainer is 22 gauge and it's thin walled, I'm able to apply high infusion pressure and I didn't have to widen the incision. That's really the biggest annoying thing about the other 20 gauge AC maintainer that I was using before. And, that incision, therefore, is not interchangeable. But I was able to just pull that AC maintainer and plug it into a different incision without widening the incision. And then I was able to do some anterior vitrectomy to remove that vitreous that was coming to that incision. And I'm just finishing up the case. And so, again, my modified Yamane technique, externalizing the leading haptic, very easy and controlled technique when you're dealing with the Sensor lens. Again, you can't beat up the Sensor haptics because they're made of PMMA, and there's so many problems with the C2 Lucille lens. Even though they have strong haptics, the haptics are propellering around the optic. Not the best situation, and not sure you want to deal with a rotisserie lens and having to cut it out, removing it. It's just a bigger ordeal. Better to learn the best techniques and being very gentle on the haptics, which again, this technique with the Sensor lens forces you to be very gentle. If it forces you to be gentle, that means it's going to make you a better surgeon to execute the Yamane technique. So I hope this was helpful to you, and I thank you for your attention.